Thank you everybody for coming to join our session. I hope you found the initial session as interesting as I did. I thought there was some amazing input from our speakers there. We've got just over an hour in this session to talk specifically about workforce. I'm going to introduce my panel in a moment. You can see their faces there. Just to let you know who I am, I work for IQVIA. I run our government and healthcare practice in the UK. My background is in local government and the NHS, so I've been working around local public services for all of my career, and that's what I'm passionate about. The thing that is I suppose the common theme through the various jobs and positions that I've held is about patients and service users being absolutely at the centre of what public services are about. So I've spent a lot of time understanding and measuring the voices of patients and service users, but also the staff and workforces that serve them. I think it's incredibly important, and I'm so glad it became a big theme of the first session. It's incredibly important that workforce is at the centre of everything that the NHS and local government is about, because if we haven't got a committed, engaged, passionate workforce, then we're not going to achieve any of the outcomes that we're all here to advance. So that's a little bit about me. I'm going to introduce our panel, and then I'm going to say a little bit more about this report, which Angela flagged at the start of the first session as well. So can I ask you each to introduce yourselves? Just say a little bit about who you are and where you come from, please.
Hi, it's lovely to be here. My name's Georgie Dixon. I'm the programme lead for the Widen in Participation programme at NHS Employers. I've come from Derbyshire today, but you can maybe tell by my accent, I'm actually from Yorkshire.
Thank you very much.
Hi everyone, so I'm Emily Smith. I'm a programme lead from NHS Employers, and my programme is the Systems and Integration Programme. So we're a newly established programme, and I'll be talking about it shortly. I've come from Leeds today, but I'm actually from Birmingham, so it's quite nice for me to be back in my hometown.
Hi, and my name is Michelle Hodgkinson. I work for a company called Dearden HR. Dearden HR are a HR consultancy that works predominantly with the NHS. About 80% of our work is in the NHS. And my background is the NHS. I did 10 years in HR and the NHS before I joined Dearden just about 3 years ago now. I'm from West London, so not from up north or Birmingham, but I have spent quite a lot of time in Birmingham. It's always nice to be back.
Brilliant. Thank you very much. And I've had the advantage of seeing their slides in advance, so I know we're going to get some really interesting insights from some different perspectives on how the system works and what drives our workforce. So I'm going to say a little bit about this report to start off with. There are copies of this on everybody's chairs. Do take them away with you and take extra copies if you want to give them to other people too. For those of you who were at the start of the first session, Angela talked about the fact that IQVIA is a global business. We've got offices in over 100 countries and work with life sciences organisations and also healthcare organisations across those sectors. So we've got quite an interesting insight into what drives healthcare systems across those different countries. This report is the result of a survey that we did, focusing on 6 countries, asking about the impact of the pandemic on workforces in the healthcare system, in particular healthcare professionals working across healthcare systems. There's some really interesting insights in here, and perhaps not surprisingly, the key headline is that stresses have got worse in healthcare systems since COVID. I'll talk about some of the specifics of that. But it also says that these aren't stresses that come about solely because of COVID. They've been exacerbated because of COVID, in particular in some countries, and as you'll see, in particular in the UK, but they're not new things. And through some of the work that we've been doing over the last 10 or 15 years around the NHS, we know that lots of these pressures in the workforce have been around for a long time. So these aren't entirely new problems. One of the first things we asked about was increased workload. And what this slide's showing is that on average there was an increase in workload caused by the pandemic. It's not a huge amount, so average case numbers have gone up from 118 to 124 across the countries that we looked at. It's quite a small increase, but on average there is that increase. More interesting is when you look at the impact across different countries. So this is showing those 6 different countries we looked at. The most obvious thing here is that the UK is a real outlier. So the increase in caseload for our healthcare professionals in the UK as a result of COVID is much, much bigger than across any of those other countries. And we'll see some similar things as I go through some of the other areas of this survey. So the next thing we asked about was some of the sources of stress for our healthcare professionals. I won't go through the whole slide, but you can see starting at about 10 o'clock, workforce shortage is the highest. 67% said that this was a particular issue as a cause of stress, followed by uncomfortable work environment at 58%, lack of work-life balance also at 58%. And again, there's some real differences across different countries. And if you look at the UK column, in particular, you'll see some of the highest numbers for those sources of stress are in the UK, particularly around workforce shortage and increased workload due to backlogs, huge patient backlogs. So some very different dynamics in the UK and some exaggerated dynamics in the UK compared to those other countries. The next slide looks at the impact of these stress elements on the ability of healthcare professionals to care for patients. And this has been a real theme of lots of the work that we've been doing over recent years, is looking at the relationship between how staff feel at work, how engaged they are with their organisations, and the experience patients have under their care, and therefore the outcomes that patients experience. So this is saying that of those stressors, some of them are much, much more correlated with patient care than others. Increased workload, patient backlogs again are the highest in this space. And again, we see much higher figures in the UK than in many other countries. So patient backlog, 78% of our HCPs in the UK said that they were impacting on their ability to care for patients. So lots of, and there's lots of other facts and figures in the report. Please do look at it. It's really interesting. And as was mentioned in the first session, it just sets a context that says that the UK is not alone in lots of these pressures and challenges, but it is exaggerated here compared to lots of the other countries that we work in and that we've looked at. So that's a bit about the global scene. A couple of slides focusing in on the UK. So this is the latest results from the NHS National Staff Survey. Many of you, I'm sure, will be aware of that. It's a survey that's carried out every year across all NHS organisations. We run it in just over 50% of NHS trusts. This slide is showing the results for England as a whole, which are the darker bars, and those in the Midlands, which are the lighter bars. Very, very similar results in the Midlands as in the national picture. And these 9 different areas are the so-called people promises in the NHS, which focus on different areas of staff engagement. Each of these is built up of about 10 or a dozen different survey questions. And as you can see, there's some different levels of score in different areas. Compassion and inclusivity always scores very, very highly. Reward and recognition and learning and development are often some of the lowest scores. So these are quite consistent scores that we see year on year, and that difference between them. These are now quite old scores. These are from last year. The survey for 2023 is currently in field work, so we've got questionnaires out there and being filled in at the moment, and the results from that will be released in the next 3 or 4 months. So it's a year or so out of date. This slide shows 3 specific questions from the survey. These are questions about advocacy that staff show for their organisations. They're my favourite 3 questions from the survey, and those that I always turn to when I'm looking for a measure of the health of an organisation. So this is about staff in the NHS saying that they would recommend the place they work as somewhere to be treated or as somewhere to work. And the obvious trend here is that you can see these 3 questions have dropped massively over the last 3 years. So the first score here is in the autumn of 2020. So when staff were filling this in is the time we were all standing outside our front doors banging pans and congratulating everybody. The scores that year were quite high compared to previous years. They've dropped significantly over the last 2 years. And actually on these three, the Midlands does lag behind the national score. But these have dropped by over 10% in some cases, which is really very significant for this survey. I'm going to stop on that perhaps slightly pessimistic note. I'll come back and say some much more optimistic things when I do my next little slot in 10 or 15 minutes' time. But I just wanted to leave you that as a context for what our next speakers are going to talk about in terms of some of the positive work that's going on in the NHS. I'm very happy to take any questions on that, or if there aren't any, I can move on to Michelle, who's going to run the next bit of the session.
More of an observation. Daniel, just staggered at the disconnect between the UK and other countries in terms of caseload. Any thoughts on that? Or any observations that have come out from the publication?
I think, unfortunately, the publication is just looking at the quantitative results, and what we're trying to do is to follow that up with some qualitative work to understand what's behind some of those figures. I think as I said at the start, it's not just as a result of COVID. I think, and it's a one-off survey. It would be really interesting if we'd done the same thing prior to COVID, and I suspect the UK still would have been quite different from some of those other systems. Michelle and I were talking about it before the session, actually, and we both know people who work in the Australian healthcare system, where generally speaking, what we hear from people is that it's a better paid system, it's much better staffed, people have a much better work-life balance, despite the fact that it's modelled largely on the NHS. And it's a result of decades of investment going in different ways, I think. I don't think there's a straightforward answer to it.
Not just one answer, it's multifaceted.
Yeah.
I was just going to answer to that. So some of it is that the UK has the lowest doctor per capita ratio. That's, so when you're talking about caseload, that is part of it, as well as obviously patients. If you help out with systems and preventative care, then it's all going to go further downstream.
Yeah, I think that's right.
I've worked in Australia for 13 years, it's
okay.
those things.
It's not just our friends.
It's not just our friends and family.
There's so much better there. But it's very different culturally. So I would say one of the biggest things is that things have changed in terms of how people view work in Australia. Is that jobs? I'm a doctor, but jobs, it is a job, not a duty, not a vocation. It's seen as employment.
And it's interesting. I said the same.
It's different to here, where there's this big. Yeah, and that you feel guilt. There's a huge amount of guilt that's kind of associated with working clinically here. You must do more.
I said the same thing to Daniel before. My friend who works in Australia described it as they work to live, not live to work. It's about, yes, it's a job. And that's not to say, certainly my friend is a doctor as well, cares very deeply for the patients that they see, but it's, I think, a different mentality. What we wanted to talk about is that retention element. So a lot of what you hear in the press in particular is about bringing new people into the NHS. We need more staff. But actually, if you're bringing more and more staff in, but more and more are leaving, you're not actually affecting the balance overall. And it's my own personal hobby horse that retention isn't looked at as well as it should be in the NHS, in my opinion. I just wanted to set the context a little bit, though, because turnover is a normal part of working life. People do come to an organisation, stay for a few years and move on, and that is completely normal and not something that we should worry about. And actually, if you look at the economy as a whole in the UK, over a third of UK employees leave their job every year. So you're talking about a massive number of people who are moving around. And actually, in health and social care, that's even higher. It's about 37.3% of staff leave their job each year. And this was something that was alluded to earlier in what Bruce was saying. So at the height of the pandemic, there were figures that were showing that we were about 115,000 FTEs, so full-time equivalent vacancies that in the health service. And that actually that's going up, and by 2030, it's going to be somewhere around 500,000. Now that's a massive amount of people to be short in the health service. And yes, we can do things around recruitment. Yes, we can bring more people in. There's things we can do around training, as Mike was saying. But actually getting people to stay, encouraging people to continue in jobs that they mostly enjoy. Most people do enjoy the jobs that they're doing, is a really important part of that. And not just because of the cost that is associated with people moving on. You'll see I've put up there somewhere around 10% of nurses leave an average NHS trust every year. That costs somewhere around 3 million every year to replace those. And that's at an individual trust level. So multiplied across the NHS, that's a huge amount of money. But it's not just about the money. It's about losing people's skills, people's organisational memory. So what's gone on in this organisation, that's held in individual people's hearts and minds. And when they move on, you lose that. And so it's a really big thing that needs more focus, in my opinion, than it currently gets. But I was glad to see that the NHS long-term plan does talk about it in a lot more detail than they have in previous iterations. And supporting current NHS staff is one of the things that's mentioned specifically in there. Now, I appreciate everybody in the room is not NHS, but this applies just as much to other organisations as well. So forgive me, with my NHS background, that's where I tend to go. But I do believe it applies to other industries as well. So I'm going to ask you to do a Slido as well. So if you've got your mobile phones, if you can point them at the QR code up in that top left corner, I'd be interested to understand whether the organisations that you work in at the moment are doing specific retention activities. So what is it that you're doing, if any, or are you doing anything to actually keep people within your organisation? So at the moment, about 2/3 of people in the room are in organisations that are doing specific retention activities. Does that sound about right? And what are they? Do you mind me asking? Who's going to volunteer? What is it that you're doing in your organisations at the moment to try and keep people employed? Go ahead.
So I chair a GP collaborative.
Okay.
So we're looking at portfolio working, particularly for those people who are more experienced in their careers, so offering the ability to virtually work.
Yep.
And that we can recruit to that, but we can't recruit to the traditional model.
Traditional, yeah.
And we've got a number of flexibility packages which we can offer for different roles. And we're trying to take a flexible approach with productivity. So if you benchmark and standardise productivity, then you can be much more flexible on the way people work to allow them to fit their lifestyle.
Yeah. So working flexibly is a big part of retention, isn't it? And I think with everything that's happened since the pandemic, people kind of expect it in a way that you didn't before. So as I say, I work in a HR consultancy. This is part of the work we do. Unfortunately, I'm involved in a number of employee relations issues as well. And I've seen a number of grievances from people saying, I worked at home for the best part of 2 years, and now you're asking me to come into the office. I don't think I need to be in the office anymore. Why can't I work at home? And so people's approach to work has changed quite significantly, I think, in the last couple of years. So that idea of working flexibly, I think, is now a big part of retention. Is there other things? Yeah.
Just a comment on that. But aren't you, especially if you're a GP, you're there for the patient's needs, and that's what you've signed up to do. And you've got a community of patients. Say my mother's age 84. They want to see a doctor face to face. You know, I'm quite happy. Depending on what it is, or you know, need to speak to them. I'm quite happy. I also do private doctors over the phones. So I haven't got a problem with it, but we have got a generation that prefer to see doctors face to face. So what do you do then with those patients? Is it the older doctors that are willing to go in, they've got to see the patients face to face? Because I'm telling you, they will not take up. And it's sometimes, you know, I hate the world we live in, I must say, with all this technology. I do, because it doesn't always work. I mean, I'm supposed to have meetings at home where I live, and I haven't got good connection. So I can't do Zooms or groups or whatever it is. I can do telephone, and even that is a bit hit and miss. And so we need to get used to that, because people tend to think you've got good internet everywhere, you haven't, even in cities, you know, Wolverhampton is a city. But the other thing is, just for instance, yesterday I took a call from my mum about something, and the woman, English wasn't her first language. That's fair enough. My mum could understand what she was saying. She kept looking at me and saying, do you understand what she's saying? You know, and that is another problem we've got with telephone calls. So if you get someone that comes from abroad and their English isn't, you know, clear enough, a lot of older people can't understand them. So, you know, when you're telling people, oh, make calls or do things over the internet, it really annoys me. Because as someone who's a carer and also works with the elderly, you know, and also with our future clinicians, we need to bear that in mind, especially with the younger people, because they think technology is everything and it isn't.
Yeah. I think did you want to come back on that?
Yeah, I think it's not a binary issue. So I think, so for our virtual GP service, for instance, to enter into it, you answer two questions. First, do you think this is something that can be dealt with on the phone? So the patient self-selects. Second thing is this something that you require continuity with a particular condition from the practice? So if you say yes, you don't get through. You get put through. And actually, there's a lot of people who do answer those questions, do go through and prefer it as an option. So, and then that gives more time for the segment of your population who require continuity, who have complexity. So I think it's not a binary thing.
No.
I think it needs to be done sensitively. But I think, absolutely get your point that, what's right for one person is not absolutely right for another. So it's...
You'd be wasting your time asking that question to my mum, because she's only going to tell you face to face anyway. Other people, fair enough. You know, most of the generation probably will. But the older people, they want what they normally have, face to face, regardless of what it is, even if it's a question. But, you know, as a pensioner, but a retirement member myself, I advocate big for the elderly, because technology is not their thing. Younger people, yes. Older people, no. You know, some are better than others, but the majority, and I'm part of a group of retired members at Unison where I used to work with social services, they were prepared, they've got a school in Birmingham, that they'll teach people to go on the internet and do things. They said, no, thank you. And we must respect that.
And I would agree that I don't think it's binary. And actually, I don't know if a nan-in-law is a thing, but my husband's nan is still alive. She's 99. And she's actually quite tech savvy for somebody who's 99.
I'm not saying everybody.
No. And I think it's important, as you say, that we take into different views.
I think what's been raised around this generational divide is actually a huge part of recruitment and retention. I think there are massive differences about
what
younger people are looking for in employment and what older people and how they would, and I think this is what comes into play in health all the time, in terms of, I don't see any, with younger people, it's not everybody, but I don't see the loyalty to an organisation that used to be there. People are happy to move. If I'm not happy here, if you're not going to provide me with the things that I believe I need to thrive, I'm moving. Whereas I think my parents' generation probably would just say, that's a good job, pays the bills, I'm happy to stay here for 20 years. So I think it's really interesting in having that sort of broad package. So my organisation has a lot of training opportunities for people, so that there's some variety on what people are looking for. I think people who might be near retirement, for example, I've got someone in my team, they're looking to go transition into part-time work.
Yeah.
So it's hard. I think it's really hard to please everybody, actually.
Well, and it was part of the reason I asked this question, because retention is such a massive subject. So obviously flexible working is one of the things that can affect retention, but hopefully on my next slide you'll see there's all sorts of different things that actually could be considered retention initiatives. So flexible working you'll see somewhere in the middle there, but things like development, career planning, flexible retirement, so starting to work part-time from an earlier age, being more involved, so being able to make change in your organisation. For some people, that's a really key thing and will keep them in the organisation. Actually, the way they're treated by line managers, how they're managed on a day-to-day basis, that will make a massive difference to retention as well. So what I've put up on the slide there, so both NHS England and NHS employers have now got retention guides. And those activities that I've listed are from the NHS England guide, but they're very similar in the NHS Employers Guide, and they exist for lots of different other industries as well. But the one I wanted to talk about a little bit today, because I think sometimes gets a bit overlooked, is this first one. So looking at data in depth, what do you know about the people in your organisation, and how can that help you retain them in your organisation? So I'm going to ask you to do another slide, Dave. So what data do you currently use to inform retention activities in your organisation? There is a none option on there if you're not using any at the moment. And if there's things that I haven't put up there, because I could have put lots, do feel free to select other, and then I'll pick on you and find out what those are as well. But I'm interested to know what data people are currently using in terms of retaining staff in the organisation. Oh, we've got a nice split there, three-way split.
And I think the way we've set the slider up, you can only pick one option.
Oh, can you?
So people need to pick the one that's used most often.
So if you pick the one that you use the most often then, and we can talk about the others as well. So I think the one that's coming up, seems to be the biggest at the moment, is conversations with existing staff. So is anybody willing to tell me what that looks like in their organisation? How are you talking to your existing staff about retention? Yeah, go ahead.
Staff forum.
Okay.
Run by staff with an elected chair.
Okay.
Staff,
Mm-hmm.
Go and listen.
Yeah. And do you get some useful insights from that?
Useful. So
Yeah.
A few initiatives that we started.
Mm-hmm.
It was particularly last winter we had a lot of welfare issues,
Mm-hmm.
so we put in some welfare funding.
Yeah.
It didn't actually cost that much money.
No.
It made a big impact.
It's that like cost of living stuff. It was really tricky, wasn't it? Still is, but particularly over the winter, I think, with the heating and etc. Were you going to say something? Yeah.
So we were in a funny position. So I worked in the vaccination programme.
Mm-hmm.
Of course, we saw the end of an era with all of our staff disappearing.
Yeah.
All often retired returners.
Yeah.
All very highly skilled. Most of them ladies, but not all. And we just saw them all disappearing off to Sainsbury's. So we snatched as many as we could in doing child immunisation.
Okay.
So they can support the workforce
To
all
keep
year
them.
round, not just seasonally. So we've got this little huddle of ladies of my kind of age.
Mm-hmm.
And so we once a month do a little Zoom meeting where they all get to come along and learn as much as they like, or we try to be constructive.
Mm-hmm.
Yeah.
Yeah. No, but that's useful, isn't it? Okay. Go ahead.
My trust, they have engagement events.
Mm-hmm.
Some in the summer, some in the winter.
Yeah.
Where they do ask stuff what's important to them.
Mm-hmm.
One of the issues that came up was around welfare as well.
Yeah.
So they've opened up welfare hubs.
Mm-hmm.
Just not during the breaks, just to chill out if they need to, just zoom out for a bit.
Yeah.
Which they've been received very well. And they've got, they do welfare sessions for staff as well,
Mm-hmm.
where they can go and have conversation.
Yeah. Yeah, so I worked in the NHS during the sort of height of COVID, and I can't remember what it was called now, but we had, airline staff who weren't working at the time came to the hospital that I was working in and set up what they called a wellbeing hub, but it was called something and it's going to bug me because I can't remember what it was called. And they came and basically did their normal kind of airline assistant hostess type role, but with our staff. So when they were having breaks, they could go down and someone would make them a coffee and get them a newspaper, and it was lovely. Unfortunately, it didn't last post-COVID, but I'm going to have to remember what that was called.
Yeah, we had the same as well.
Mm.
So we had EasyJet crew.
Yeah.
I had British Airways first class cabin crew and I was training them to be vaccinated. So
Oh, really? Oh, well, that sounds amazing. Oh, great. Okay. So I suppose the conversations with staff and the qualitative information that you get out of that is really, really useful. But I wanted to talk to you a little bit about a case study. So this is a project that I've personally been involved in and recently finished. So we were working with an operational delivery network, radiotherapy operational delivery network down in the south of the country. So this is actually 4 NHS trusts who work together to try and deliver radiotherapy in a particular area. And we did quite a long project with them looking at the current demand that they've got for services, but then also looking at their workforce status. So as Daniel alluded to, all of them felt like their workload has increased since COVID. They were really struggling. They had lots of vacancies and they wanted to take a proactive approach to what is it that we can do to try and help this. So we looked, as I say, at current demand and then modelled some future demand for them so that we could get an idea of actually how many staff do you need now and in the future to deal with some of this stuff. And then we worked with them to try and say, okay, so we've told you need an extra 25 staff or whatever it is. This is the types of actions that you can take to try and get those people in. So some of them were around recruitment, some of them were around training. They're doing some apprenticeships for radiotherapy, etc. But the one in particular around retention was we did some data modelling around retention. So what we did was analyse employee information. In this case, it came from ESR, the electronic staff record that exists in NHS trusts. And we used that to produce a forecast of staff who were going to leave. So we looked at people who left in the last 5 years and analysed various different demographic information, in inverted commas, to then give us a sort of predictive value of people who are currently employed. How likely were they to leave the organisation? So this is my last Slido, so I'm going to ask you just to get your mobile phone out one more time. What factors do you think had the highest correlation with people's propensity to leave? I've put a few up there. Again, if there's others, I'm more than happy for you to shout them out for me. So distance travelled into work, salary, the length of time they've been employed, age, area they work in, personal circumstances, etc. So what have we got coming up on here? So salaries, obviously, looks like a few people have picked that one. And obviously we hear a lot about NHS salaries at the moment in the press and through the strikes and everything that are going on. Length of time employed is the other one. Yeah. Okay. I will admit this is a little bit of a trick question, so apologies. But what we found, as I say, the ODN that we worked with was 4 individual trusts. So we did this in the 4 different trusts. And we found it was very different in the different trusts that we worked in. So one trust, the most common factors linked to people's risk of leaving was around salary, the length of time they'd been employed in that organisation and their age. But then the other trust that was only a few miles down the road, their factors were different and they included things like whether the person was working full or part-time, their sickness record, and then their time in role. So the difference between length of time employed and time in role is, so someone might have been employed 10 years in the hospital, but they've only been in their current role for the last 2 years. And actually we found if people had been in post in a particular role for a long time, that made they were much more likely to move on. I'm mindful I'm talking too much, so I will speed up. But what we did was use this data then to get trust to take a really proactive approach with their staff. So they actually examined their ESR list, looked at people who, according to this data model, were most likely to leave the organisation. And then we asked them to have what we called stay conversations with people. And hopefully, dotted around on your chairs, you will find a template for one of these stay conversations. Now, this is work that we developed with the NHS, so it's not owned by me or by Dearden, so I'm very happy for anybody who wants to use it. You can amend it if it's useful. But what we found was that it was a really practical way, and it's quite tricky for managers to sit down with people and have these open conversations. But actually, if they did, they suddenly found out things that they didn't know before. And as I say, this piece of work was only completed last year, so we've been tracking it over the last year. But the leaver rates in all 4 of the organisations that we work with have dropped since then. So slightly differently in different places. Some have dropped more than others. And I'm not saying this is the only thing that's affected that, because it will be multifactorial. But this is one way of targeting the sort of retention element of the workforce challenge that I think all organisations in this room are facing at the moment. And now I'm going to be quiet because I've talked too long. If there's any questions, I'm very happy to answer them, but I should probably hand over to George.
Michelle, that's been really good. Thank you so much. Some real insights there. The thing that's really stuck with me is that the difference you found in different organisations about why people leave. Because I think often we can just badge the NHS as a single thing and expect the culture and the issues to be exactly the same from one trust to the next, and they're really not.
No.
We find exactly the same when we're having conversations with trust. It's very, very different depending on the organisation and its individual culture. I think that's really worth remembering. I'm going to ask you to hold any questions till the end. We're going to be kicked out of here at past, and I'm really keen that we get through to our NHS employers speakers as well. I'm going to do a few slides very, very quickly just to add some more slightly more optimistic stories to what I said earlier on about the NHS staff survey, and then I'll come back to you. This, I suppose, just underlines some of the things that you were saying, Michelle, in terms of there being a whole range of different mechanisms that drive staff engagement. I've talked a lot about surveys, which is in the top left-hand quadrant of this picture. There's lots of other tools and techniques that NHS organisations and any other organisation uses to understand its staff and to drive staff engagement. And as it says at the bottom, that in our experience, the best performing organisations that we see are using a whole variety of these different mechanisms at the same time in order to make sure that they understand their staff and they understand what's driving their staff to stay in the organisation, hopefully as long as possible. I made a very quick reference to this earlier on. I'm happy to talk to anybody more about it in the break. But we do lots of work in staff surveys, but also in understanding patient experience and patient outcomes, which are the other 2 circles here. And what we found is that there's a real overlap between those different areas of work. So where you have, and this probably sounds obvious, but it's really quite interesting if you look at the science behind it, where you have engaged staff who are enjoying their jobs and doing their jobs well, there's a very direct relationship with patient experience going up. So and I guess the same applies in any customer service environment. If you've got staff that are enjoying their jobs, then it really rubs off on the experience their customers are having. But the bottom bit is even more interesting, which is that if patients are experiencing good care when they're in hospital, then there's a direct statistical association with improved patient outcomes as well. We did some really interesting work around elective surgery in this space. So there's that very positive loop between staff engagement, patient experience and patient outcomes. This is just showing some of the really key themes that have come out of our work on that NHS National Staff Survey that I talked about over the last 20 years or so. Many of these have been referenced either in the initial session or in what Michelle said, so I won't dwell on these. And then I've just got the 3 examples of some really positive case stories where we've actually shown some improvements in these scores from 1 year to the next in individual trusts. Often we'll go into the same organisation year after year and staff experience scores stay about the same. And people say, oh, it's impossible to shift it, it's just the organisational culture. Actually, you can shift some of these things quite radically from 1 year to the next, often with really simple interventions. So this is an organisation where staff were simply reporting in the survey that they didn't feel valued. And the very simple intervention that happened, and lots of organisations do similar things. The chief exec in this organisation started sending personalised postcards to people at home, signed by the chief exec, thanking them for things that they'd done. Not everybody, but selected people who'd done particularly good work or worked exceptionally hard or had done something special. And this became widely known across the trust and made a really big difference to people feeling valued and appreciated in their organisation. Really simple, really cheap initiative. This is an example around harassment and bullying, and this is something that was mentioned in the first session this afternoon. Harassment and bullying is high in the NHS compared to other organisations, but both from patients and from other members of staff. And in this organisation where we worked, it was particularly high compared to other trusts. The fairly straightforward intervention was to talk to staff about what was going on. So it was, to come back to your question earlier on, Jim, about why some of those scores are high, this organisation talked to staff and got the qualitative input into those quantitative scores. We helped facilitate some of these focus groups, and there were some quite straightforward interventions that followed. Anti-bullying champions, some very targeted communications campaigns around bullying, and improved reporting internally about what was going on in bullying and harassment. And as you can see, a really radical reduction in bullying, in this case bullying from other staff within the trust from 1 year to the next. And then the final example is around staff appraisals, personal development reviews, dissatisfaction reported with that process, and some very straightforward interventions to review that process across the organisation. A staff survey working group set up to look at how that can be improved, and a noticeable increase. We haven't got the figures on this one. Noticeable increase from 1 year to the next. So some much more positive stories about what can be done by looking at some of the data in these surveys and taking some quite straightforward actions to move things forward from 1 year to the next. That's me. I'm going to hand over now to Georgie, I think.
Thank you.
To talk a bit more about staff participation.
Yes.
Thank you.
Hi, no, it's nice to be here. Thank you for having me. So I'm going to talk a little bit today about anchor systems and widening participation and the work that we're doing to support employers in this space. So this is obviously quite illustrative of what a system looks like. And these are the 4 key aims of integrated care systems. So I'm here to kind of make the case that integrated care systems exemplify anchor institutions, particularly focusing on that 4th aim there, helping the NHS to support broader social and economic development. And that is, in essence, what being anchor or acting as anchor is. So good work is good for our health. This was one of the key takeaways from the Taylor Review, which was back in 2016, but several studies since then have also kind of made this case as well, and really shown that link between the quality of employment and the jobs that we have and our health. So what does good work look like? Well, these are kind of 4 sort of key components of that. But I think what's also quite interesting is the interrelation between income and social status. I think we can largely argue that our social status is defined by the jobs that we actually have. And interestingly enough, the Prince's Trust and the young people's social media platform Lad Bible just produced a report about redefining dream jobs for Generation Z, so our young people of today. And interestingly enough, despite all the bad media and press about working in health and social care, medicine, health, social care and welfare ranked as the top dream job industry for young people. However, what that report did reveal was all the barriers that young people now face to accessing this employment. So yes, what does good work look like? So if you are an NHS organisation, you're probably the largest employer in your area. you're potentially delivering anchor work already and you don't realise it. So that could be in the form of apprenticeships. Maybe you offer T-level placements, advanced practice opportunities. Maybe you have functional skills training for English and math, on your hospital sites. Or maybe you are a real living wage employer. So the Widen Participation Hub, so this is something that we've recently published that's kind of bringing together kind of all this thinking, ideas and good practice. So working together, systems provide integrated care for the populations that they serve. So this includes your integrated workforce planning and organisational development, the joint teams that you have, the training that you offer, and the rotation that staff have between health and social care settings. A really good example of this is a rotational nurses programme at Joined Up Derbyshire that they've been sort of talking about all around the country now, and it's been very, very successful. So it's quite a good example of that as well. So an approach that's crucial for public health services is one that addresses population health needs, because we know that, and I like to think that a lot of us recognise that our communities face increasing healthcare requirements, particularly in correlation with the cost of living crisis. So being an anchor employer, to bring it back, so this means being a more inclusive employer and widening participation and providing more equity of access to jobs for our communities. It's driving and supporting that broader social and economic development by offering good work and skills development, particularly digital skills. I think everybody thinks that all young people have digital skills, and this is not the case. It's also your interpersonal skills, so applying for a job, what does that entail? It means a job interview, it means a job application. Social mobility programmes that are being offered, and they're therefore improving the inequality, and improving health and wellbeing and ultimately income deprivation in your area. As I am NHS employers, I will bring in the impact of the NHS long-term plan. So just some highlights in relation to what I'm talking about today. It's expected that organisations will need to recruit from a much wider labour market going forwards to meet that workforce demand. They're saying that in 15 years' time, somewhere between 204 and 230,000 more staff will be needed to support clinical roles. About 47 to 57,000 of these will just be healthcare support workers. So you have to expect within such a large number of people, there will be a huge variance in skills, qualifications, education, and all those kind of things that I don't think are necessarily considered. So we need to widen participation to create an inclusive workforce that is actually representative of our local demographics. So this Venn diagram here, these are sort of the key areas that the Widening Participation Hub explores to kind of show the interrelation of the different parts of what anchor working is in relation to employment, skills and training. We've also produced an infographic tool which explores the 6 key areas of being an anchor employer and what that actually involves. I won't go through all those in detail. I am mindful of time and sort of giving time for questions as well. But some of those are sharing and learning ideas. So we've provided a widening participation network for NHS employers nationally, where we are trying to create that kind of learning space and sharing space for good practice and what anchor activity actually looks like in different areas. There are similarities, but there's also a lot of differences as well. And good practice. So what does being an anchor employer look like? And this is where it gets really interesting, because as much as system working is incredibly important, a lot of this activity, if not most, in my experience, happens at place level. And it varies so much from region to region because different communities have different demographics, have different needs, have different cultures, etc. So just to kind of cherry pick a couple, North Cumbria Integrated Care, they actually have an anchor project manager in place. They've worked with job centres, housing associations, social prescribers in primary care, charities and various other VCSEs, your voluntary community and social enterprises. And they've created a Step Into Work pre-employment programme where they provide one-to-one mentorship They provide clothing for interviews for people that don't necessarily have smart clothing, they can't afford to buy it. And what they've actually found by doing this really sort of grassroots community-based work, it's hard, but it garners results, so it's self-perpetuating. So what they've actually recognised is that the successful candidates that have gone through this programme, their family and friends now want to access the same opportunities. So it really is that kind of self-perpetuating community sort of based work. Leeds hyperlocal sort of recruitment approaches. So they've been on the ground, giving out flyers. They've set up team leads hubs where they're actually having conversations in and around the city with people about career aspirations. What do you feel that your barriers are to accessing employment? So they had, from one event that they kind of ran in different areas of the city, they had 300 expressions of interest and they had 30 successful recruits, which included some registered nurses that went through a TNA programme as well, which was excellent. And then finally, I'll just touch upon the guide that we've produced to kind of support this, which is the how to support systems to be anchors. So within that, there are various pieces of good practice such as these that I've just sort of cherry-picked and highlighted today, and information on there about place-based partnerships and how to actually start curating those and fostering those relationships in your community. And that is a bit of a whistle-stop tour, but thank you very much. And I'm going to hand over to my colleague Emily now.
Thanks, Georgie. Hi, everyone. Oh, that was your slide as well, Georgie. Hi, everyone. So, yeah, really good to be here today and to hear all of the different speakers and to have dedicated time to talking about the workforce on the agenda. It's really good to see. So, I just wanted to talk about the new programme that I'm leading, the Systems and Integration Programme at NHS Employers. So, predominantly, NHS Employers, did what it says on the tin, supported employers in the NHS. However, with the new establishment of the integrated care systems, we have developed this programme to strengthen the connections around ICS workforce issues and NHS employers and the NHS Confederation ICS network. So our programme creates a focus and a space where system stakeholders and ICB workforce leads can come together to champion and support the one workforce vision. So that's just a bit of context there. So what I wanted to focus on today was some of the guide that we published last October, which was integrated workforce thinking across systems. Forgive me, I do have a postcode for everybody with a QR, but I did forget to put it on your chair. So I will give it to you at the end so you can get directly to our guide if you want to have a read. But basically, we started having conversations with Skills for Care, who represent the social care workforce, and Partners in Care and Health, who are a combination of the Local Government Association and ADAS. And we set up a bit of a steering group as we wanted to support systems in understanding how they can integrate their workforce thinking across the system. So we did a lot of engagement with a lot of different people. It was really interesting to understand that there were a lot of different definitions around integrated workforce planning, which is what we originally wanted to call the guide. However, we noticed that the definitions on workforce planning predominantly focus on finance and HR and operations. So we coined the term integrated workforce thinking, which is when leaders across the system work together to consider population health and care needs and their system strategies so that they can plan for a workforce that delivers person-centred care within their communities. So this was a really positive piece of work where we just started the conversation, and it was really powerful for our organisations to come together collectively to say the same message, which filters down to the workforce. So our guide shows that successful workforce integration can provide a positive experience for people who draw on care and support in the context of their whole lives. It was a bit of a learning process. Obviously, we had to integrate our 3 organisations to produce this guide, and we learned a lot around culture, language, challenges, and shared expertise, which was a really valuable experience, showing that integration and understanding each other's world is really important in creating that shared vision. And we personally, from NHS Employers, have learned a lot from working with ADAS and Skills for Care, especially around this delivering person-centred care and what the workforce is needed to deliver that. So, my next slide. what does integrated working look like? So to do this, we have created a lot of different case studies to just kind of show where this work is happening across the system and how this is benefiting the workforce. So I'll kind of touch on one example, which most people, you might have heard of, which is Hull and North Yorkshire ICB. So they created a hub called the Jean Bishop Centre in Hull, which is the first ever centre for fragility. And they did this as I looked at their population health and saw that they had a very high retirement population. People want to go and live by the sea. So they're moving away from their families. So a lot of people who are accessing local health and care services were to do with fragility issues. So they set up this Jean Bishop Centre where they integrated social care, health, primary care, mental health services, fire services to come together to provide support for people in their communities to help them understand how they can start preventing falls from happening and them ending up in hospital, and supporting them to age and live well. It's a fantastic example, and they've created such a positive culture there. For example, I think they were really struggling with recruitment in Hull, and they advertised a role last year, 2 roles, and they got 37 applications, and they were like, that is just out of this world for Hull. They can't get people to stay and work there. And this kind of growing their own workforce, training them, people want to work in an environment where they're learning from social care, from mental health, from primary care, and they're being educated in this space, and therefore working in a space like that, improves retention, they're being upskilled, and it's created a really positive space for them to work in. We've also got a couple of other case studies there as well, but I am conscious of time, so I won't touch on them, but they're all on our website for you to take a look at. And then I just quickly wanted to talk about a new resource that we published in September, which was called 6 Ways to Create a Culture for Integration. So we really wanted to build on the thinking that we've already started talking about in our Integrated Workforce Thinking Guide, which was around how culture is an integral part of building a more integrated workforce. Historically, organisations within systems have been working in silo, so it's important that culture change is addressed from the offset. And I know in the first session today, they were talking about culture and the importance of that. So we've pulled together these six ways. We're not saying anything revolutionary. We know that this is, what everybody knows. However, we just wanted it to come from all of us saying the same thing to deliver these messages, as we understand through our engagement that culture is still a really big barrier towards integrating services. We did a bit of an engagement session at NHS Confed in June, and we understood that this is something that is really challenging for a lot of ICSs, towards integrating care and, providing better support for the workforces in that place and using them as a priority. And I think when a lot of ICBs are kind of working together and looking at their population health, a big part of the population health is the workforce, and you have to have the workforce to be able to deliver the care. So if the workforce aren't well, you're not going to be able to deliver the care. So it's including them in everything that you're looking at. And this goes back to kind of upskilling, providing training opportunities, as the people on the panel have been discussing today, and that's something that's really important to people in that space, and flexibility. So that's something that we touch on in this guide as well. And this is just a little visual that we created. So we had a webinar in late September where we just had a really positive conversation about culture, and heard from some really good speakers who are doing some really positive work across the system around what they've done around culture and how they have integrated their services. And we just wanted to pull together a few nice takeaways for people to take away from that. Obviously, we're not saying we've solved it all, but it was just really good to have a conversation and to hear how culture is still a real big barrier towards this. And it is very much still the start of this conversation, and we are planning on doing a lot more work in this space to help people to understand that. So yeah, I think that's all my slides there. We did have some questions, but I think I might hand back over to you and we can kind of navigate that for the last 10 minutes. But
thank you. Thank you so much, Georgie and Emily. We have got about 10 minutes left for questions. I am going to remind you who everybody is. We had a few questions submitted in advance, but given the time, I think what I might do is just ask everybody in the room for any questions or any reflections on what you've heard. The point of this session was to learn how to do things better in organisations around workforce, and the big takeaway for me is that we've heard loads and loads of really valuable content. I can't wait to read the guide that you've talked about.
Oh, thank you.
I think there's lots there for us to think about and take back to our organisations. But any questions or thoughts from the floor? The back. Thank you.
Just a quick question. Have there been any studies done to see how efficient staff working from home are as compared to working on site, for example?
Nothing specific that we've done. I don't know if you've come across
There
anything in
is
the NHS.
research that shows that actually people are generally more productive at home than in the workplace. But that's from lots of different sources, and it's not something that Dearden have done specifically, so I wouldn't want to own that completely. But I did read a survey last week that said people tend to be more productive at home, even with, I think it was something like 50% of people admitting that they might stick the washing on or hang out the washing during the working day as well, because people are able to fit in other things and work flexibly. It has been shown to be more productive than being in the office. My personal view is that you need a bit of a mix of both. I work predominantly from home and I love it, and I find myself very productive, but I do sometimes miss the corridor conversations that you have with people, just bumping into people, finding out about what's going on. You don't get that in the same way at home as you would do working in an office, and I do think that that's valuable. There are ways around it with Teams and chatting to people online, etc., but it's not perfect.
As a mother of a 6-year-old geeky boy, it's been really difficult post-COVID, entering the workplace, everything online.
Mm-hmm.
He's never going to get a girlfriend or a boyfriend. He's never. He's really nervous about entering the social scene. So I agree with you. I think the mix is really valuable. Social interaction and development.
Yeah. I think one of the bits of feedback we've had from running these sessions around the country is that people have really valued coming together in this sort of forum, because none of us did this for a couple of years. And we all thought Zoom's going to be the answer to it all, and we don't need to ever hire a conference venue again because we can just do it all on Zoom and it's much cheaper and it doesn't mean no one has to travel. Actually, it's much better everybody coming together, and you can have this sort of interaction in a very, very different sort of way.
But I think the challenge specifically within the healthcare system is it's a complex system. And as was highlighted today, not every task can be delivered virtually online.
No.
Certain training elements, as good as augmented reality and virtual reality is, you still need exposure to real world scenarios and patients to learn how things work in reality. So there's certainly a great value in hybrid working that opens up the workforce. It allows women with small children to come back to workplace faster. But there's it's horses for courses. There is a place for technology, for technology provided it works. And on the case of the older people not engaging with the technology, if the technology is good, they will engage. And what it enables is the release of the staff money. It takes away the burden, so it allows you to optimize how pathways are delivered, which releases the time to then service those who have additional complex needs. So it can be worked out, but it is a question of horses for courses.
One thing you're forgetting, you keep talking about different communities, is that it's another expense, isn't it? Technology. It's another expense, to have the phone, the Wi-Fi, and all the rest. You haven't took that into effect. Not everybody can afford it.
Absolutely, you're right.
Yeah,
so most of the deployments, you have to cost that in. So some of the examples that I've seen, the provision of the connectivity package and the provision of the connectivity phone or tablet or whatever is factored in, because there's a recognition that otherwise you leave people behind, and that's not fair, because very often those who can least afford the accessibility tools are the ones who need the assistance and
my mum hasn't got a phone working for now. So, that's the start, that her house phone
Got another comment at the back.
Can I just add? I just wanted to, before the lady spoke, I just wanted to add that in. One of the things that I've mentioned, I'm probably going to keep mentioning as the controversial one, because I like to live in the real world. I don't like to live in that pretend world. As somebody who's got a foot in both doors, as working and as a patient, the last time I went into hospital, I was treated so badly. I actually informed PALS that the service that I got could have been done by a robot. How concerned is our healthcare about jobs being taken over by AI? Who
wants to take that one? That's a controversial question.
It is a controversial question.
It is, because that is the way we're going. That's what we're hearing. And as I said, I was in there 9 days, nothing was done for me. This is why I put in a complaint. And I said the nurses and the doctors might as well have been a robot for the service I got. There was none of that care, and I've worked in care for 40 years, none of that care and interaction with patients. It was just about looking at your name tag. So they're just doing the dots, coming to the patient, giving you tablets, giving you meal. Well, a robot can do that. No interaction, no speaking, no saying your name, It's terrible. And that's the way, and I fed this back to the university where I work, because obviously I'm teaching the future clinicians. And I said to our doctor, we're wasting our time, because when they go out into the big wild world, what we've taught them here doesn't happen. And the one big thing I would say to you, when you talked about the interaction, is that when I complained to the matron on the ward, she asked me to come back and teach the staff. She said that she's doing a dissertation, and she said that she asked the staff how important communication is to them. Do you know what they said? Not important at all.
Really? I'm surprised to hear that.
I think my perspective on that would be, and it's not really answering the robot question, but in terms of the patient experience question, we do a lot of work in patient experience, just like we do in staff experience. And I think, as Michelle was saying about different trusts having very different cultures and experiences with their staff, we find very, very different results in patient experience in different trusts. So you described a really bad experience, which might be the case across the whole of that organisation or just in a part of it, but it's certainly not the case in every organisation where we work.
But the culture needs to change, and if we the workforce, it's just that one ward in particular, but that is done. I won't go back in that hospital again. But what I'm saying is, the staff are aware of it and are doing nothing about it. So, we don't stand a chance. I send the head nurse, sister, matron. What is the matron's role? What is the matron's role if it's not there to make sure the staff are doing the job and interaction? I don't understand why they're there. Because everybody said bring back the matron. The matrons we've got now are not the matrons we had before. The job role is not the same. Because I just think they're just making the numbers up.
I think you've asked a question which probably deserves a whole workshop.
Oh,
yes,
and I've just been given the signal from the back.
Because the NHS is poor. It is really poor at the moment. I'm sorry to say. We're not fulfilling the needs. And this interaction with social care, when is it going to happen? Because the councils have got rid of it. So when's unless that works, there's going to be more burden on the NHS, and there always will be, because there's nowhere for them to go when they come out of hospital.
Let's come back to that in another session. Thank you very much for your input, everybody. Thanks for your questions and interaction. Thank you again to my speakers.